Hey everybody, thanks for coming. This is Cameron Eldred, doctorate in athletic training student through Indiana State University. We're going to do some real quick introductions here just so that everybody knows who everybody else is. And then we're going to go ahead and we're going to talk about some spinal mobilizations within the cervical region. And we're just going to go from there. So I'll go ahead and we're going to start with Kendall. She can introduce herself and then we'll move on.
It's Kendall Dennison.
Annette Monk.
Thomas Gruffley.
Awesome. Thanks, guys. All right. So what we're going to go ahead and start with is we have two of us who were able to record a couple of videos for us. And so we're going to start with Annette Monk. She's going to go ahead and show us her video, and she's going to talk us through exactly what it is that she was doing. And we're going to discuss it. We're going to kind of go over it, and then we'll move on to the next one.
Thanks, Cameron. So on the video, you'll see me talking, but I'll talk through it here as a group. Looking at our patient here, we have, can you still hear me?
Mm-hmm.
Yes.
On our patient, we are checking her rotation first. To the left, she was normal. To the right, she is limited. This is a true case. So we are going to have her lay in a comfortable position, supine with her head close to the edge of the table. Since she's restricted to the right, that's going to be the way we bring her into rotation using a pincer grip with our forefingers and thumb on this first spinous process that we can palpate. One thing I'm doing here is making sure that she is comfortable with me lifting her head. Since she is in pain, we want to go very gently. As I am using the pincer grip, I stabilize the spinous process and then rotate her passively to the right, feeling for her end range. Repeating a second time, seeing if I can go a little farther. If she's comfortable, then I can complete small oscillations to try to mobilize as well. And one thing I showed in this demonstration is different hand placement. So using my left hand as a pincer grip provided a much better control for rotation to the right. This is something I encourage each clinician to practice on with patients, is to make sure that they can have good hand control with their preferred hand.
So what was kind of like her, do you know what the MOI was behind her injury?
She has no specific MOI. Her thought process is that she's waking up from a poor sleeping position. She's recently married, so she's new to sharing a bed with somebody and a different pillow. And so it's most likely attributed to her sleeping patterns.
You know, and it's funny that you actually mentioned that because my child is a bed hog. And ever since my child has started jumping into bed with us, like back pain, neck pain, because he steals my pillows and he sleeps horizontal. Vertical. But it's true. Like, you know, it's funny that you mentioned that because when you do get into a new habit, like, you know, you're newly married or you've moved in with a partner, it changes the way that you sleep. It changes a lot of different things with your sleep patterns. So, you know, I like that you brought that up. I do have a question for you, though. You said that you used a pincer-like grip on the spinous process, which I get how to do that. How would you approach that with somebody who maybe has a little bit more muscle in their neck or is a little bit thicker in their neck? Because like myself, like it's a little bit harder to find those spinous processes. So how do you kind of differentiate?
I think in that case, it would definitely have to be with clinician expertise. And one thing that I've found to make the muscles relax is first to do a static position. This is something I learned from a massage therapist. Using the thumb or the fingers, I use the first fingers, I'll sit statically with that on the base of the skull. And it may take 4 or 5, 6 minutes. And when I feel that head release into they're no longer actively trying to hold their head up. Once they're relaxed enough, then it's easier to palpate the spine, at least from my experience.
No, that makes a lot of sense. I appreciate that because I've always found it hard to get the patient to relax. which is a big thing for me. So I really appreciate that. Anybody else?
Yeah, so going off of that, actually, because for mine, I used Tim was my patient, and so at first I was like struggling to because for the OA you have to palpate the transverse process and use a pincer grip on that, and so I was struggling with it at first. So then he was like, "How about I just lay on my stomach?" And I had him just totally relax his neck, and then I just found it there, so I knew what it felt like. So then when he was supine, I could actually find it again and kind of know, A, first off where it was, and B, then know what kind of feel I was supposed to have, and to know if he was actually fully relaxed, or if I needed to have kind of adjust him a little bit to get him relaxed fully.
That makes sense.
Especially when you have them, if you have them hanging off the table, I tend to have them hanging off the table because I find it easier to get my hands in there. They are trying to hold their neck because they're scared that you're going to drop it. And so you just have to say I promise I have your head, I won't drop it.
Mm-hmm.
And you have to make sure that they're really comfortable. And you're put all your weight in my hands first. So we'll get there first. Yeah, definitely verbal cues. And just having them trust you that you're going to be able to hold their head up. I think it's a big part of it.
Yep, I agree. Awesome. Well, thank you, Annette.
Yep.
That was super awesome.
Yeah, who was your video recorder? They did such a good job. They're professional. We need more people like that.
And was that one of your students that was recording you?
Oh, I'm sorry. I accidentally hit the mute button. No, that was another athletic trainer that was recording me, but it was the head athletic trainer that was the patient.
Oh, nice.
Oh. All right, well, I guess I'll go now. So for mine, I did the OA mobilization technique, and my patient was Mr. Tim Andrews right here. And so just introducing myself, no need to know that. So first off, before I actually did this, I had Tim lying supine or prone as I was talking, so I could kind of understand the feeling for it. And so now this is behind this technique. You're going to use it if they're having trouble with cervical flexion. It's a very kind of symptomatic thing. So if they're having trouble getting it down, or they're having cervicogenic problems with headaches or something, this is a good technique to try. So right here, I'm grabbing the base of his skull, and I am having him fully relaxed. And so I'm using my middle finger and my thumb on either side, and then I'm kind of palpating with my pointer finger, my index, to find the occiput, to find the grooves. And then once I find the grooves, I'm then working down to find the transverse processes, so I can find C1, C2, and use the pincer technique and grab that. And so while I have his neck there, and then his head's resting kind of on my wrist, and then I'm going to grab the top of his skull with my hand, and I'm going to put him through 5 to 10 oscillations in deflection to help stretch out that cervical muscles. And so right there, you don't need a lot, and you just put them through the flexion pattern.
Was that, I mean, is this uncomfortable for the patient at all? If you're having to put your hand on the back of their head and almost grip where their skull cap is going to be moving?
So I could tell he kind of tensed up. So I think it's one thing with patient education that you have to get them to fully relax and kind of have that trust in you, because he made the joke to me. He's like, if you break my neck, I'm going to kill you. And I was like, okay, good one, because you'll be dead. But so he was it's one of those things that he knows me, and I hope he trusts me, but when you're working with a patient, you have to kind of make sure that they're fully relaxed to kind of get that effect on it.
Mm-hmm.
Yeah,
That makes
I
sense.
think that brings up a really good point about really knowing our patient. That spurred a thought to me. I don't like anybody touching my neck ever, especially if people try to come up behind me and like just a nice quick tap here, like it sends sparks down my spine. And so it's almost a thing where you want to know not their upbringing or childhood background, life story, but that should be a question we should have before all of these techniques is how comfortable are you with somebody touching your neck?
Mhm.
And that would be a good just general question for treatment.
Makes sense.
And I think at this point people know, especially Tim, people know that the neck is really important and holds a lot of important things, and so it kind of is a scary place to do stuff on. Like it's not the knee, it's your neck. It's very important. It's very close to your face, and I think people are a little more hesitant with it.
Especially when they're guarding already because they're in pain or something. So
Right?
it's like they're already cautious about it, and then you're going, "Hey, I need you to fully relax," and you're like, "I don't know if I can do that because I don't really trust you enough," and it's already sore. So it's one of those things too.
Awesome. Cool.
You want to go next?
Yeah, I can go next. So, so mine was the closing muscle energy technique. This is a really kind of a hard view. Like, I really like Dr. Powden's way of being able to like show from down here and being able to like see like the side to side motions. Like that kind of really helps. But at the same time, it is what it is, and I don't have that many cameras, so you know. So the biggest thing with this one is that we are going to use this on a patient who's got pain with rotation as well as side bending. Now, what's important to remember with this one is that we are going to be stabilizing the patient, and we can actually stabilize using like the niche of our hip if we really need to. Otherwise, we could be sitting. Annette, I noticed that you were sitting on a stool when you were doing yours. I could lower this down. I have my child's kiddie chair right here that I could maybe get away with. But my knees also sit up to my chin if I do that. So I'm going to do the way that Dr. Powden showed us. And I'm just going to use my hip just to stabilize. And then what we're going to do is we're going to allow the patient to kind of come into retraction. Now, when we do that, it kind of makes a double chin. And I kind of had to laugh about that because that's kind of how I verbally cue my patient is I say, let's go ahead and make that double chin. Let your head kind of droop, kind of drop. And you're going to just see that, you're going to see that double chin. And you're going to tell them like, hey, that looks good. Like you're doing a great job. The next thing that we're going to do is we are going to side bend towards the side that has pain when we're doing the this muscle energy technique. So we're going to side bend towards, sorry, I had to switch there so that we could see it from this side. So we're going to side bend towards, and then we rotate away. Okay, and then what we're going to do is we're going to take our hand and we're just going to lightly place it on the patient towards the patient, bottom of the patient's chin, and we're going to tell them to push up against it. And you're going to hold that. Good, relax. And then we take them to the next barrier, to as far as they can go, and we tell them to do it again. Good. Then relax. Okay, and then we always bring them back into a comfortable position, and we make sure that they feel okay, and then we can let them know that they can sit up. So yeah, that's exactly how we do the closed muscle energy technique.
I was very comfortable.
That was literally my question that I was about to ask.
It doesn't seem like it would be very comfortable. I actually was surprised because like my hip hits right at the perfect height for this to be able to like use my hip as that like niche, like being able to just get him right there in the niche of my hip. Like it was perfect.
Well, and like when he was holding me, I felt like I was like holding my head up, and then when I put his like on his thigh, I was like, oh, thank God, I don't have to like hold my neck up anymore. So
yeah.
Now, when you are having your patient resist you, are you saying things like, I don't want you to contract the full amount, or give me 50% contraction, or just don't let me push you away? How are you going to cue them as far as how much resistance to give?
So I think a lot of that's going to be based off of pain. But I mean, we're taking them all the way to their pain barrier, and then we're asking them to come towards it again. And so a lot of the times, I don't think a patient's going to be able to give you 100%. And to be honest with you, like I would be uncomfortable giving 100% if somebody was doing that to me, just because it's my neck, and that's scary, like we were talking about before. So I didn't verbally cue them, but if I didn't feel like the patient was pushing enough, I might cue them to say, "Hey, can you push a little bit more? Like, are you able to resist this a little bit more?" I don't want to force them down. That's the other thing, is I want them to just resist my hand. So we're just going against my force. We're not trying to like push me away, and I'm not trying to push them away. It's just a contraction that we're looking for. Does that make sense?
It does.
It makes sense to my.
One last question. Do you think this technique can be done seated for those patients that are uncomfortable with relaxing? So if you have them in a low stool, can you passively move their head into a position?
I don't think so, because you need to be able to get them into retraction.
Okay.
That's the problem, is you need that drop. You need them to relax enough to where they make that double chin. And
Okay.
I just don't think that in a seated position you could get like that's actually really uncomfortable, like, because at that point they're gonna still try to hold their head up,
Okay.
and your hand positioning at the same time. I mean, I just can't think of how. I mean, and I could just be thinking inside a box instead of outside of a box.
No, I don't think so.
But it just seems hard to be able to do that. I've never tried it that way, but that's a good question.
Well, I agree. I didn't find it possible, but I was hoping that maybe somebody else had a solution. But if we all are in agreement, then I think that's a good solution, or a good response.
That would be a good question for our document that we're going to make.
And so when I was looking up YouTube videos on this stuff, I definitely saw there was I don't know if it was a physical therapy class or not, but the guy was doing it seated. I'm not sure exactly what technique he was doing, because it was kind of like a mix between like the OA and like a muscle energy with the OA. So it was kind of a weird technique, but he had the patient seated. I was like, I don't know if that would be as effective as they are if they're laying down.
Well,
Yeah, like gravity is helping you with the retraction a little.
yeah. That and it
I
just
feel like I'm doing it.
Mhm. Yeah, like just muscle tension wise, I don't know. That would be a good question for Dr. Powden. I also feel like if you were doing it seated, I would almost feel like I was just doing Sperlings,
Yeah.
to be honest.
Well, I think if we did any of these in seated, like you saw on the YouTube videos, maybe it's something where we can do a our own technique that's that they can apply at home. So, for instance, when I was at GLADA, one mobilization that they showed us on that Saturday was to passively flex, rotate, or side bend, and then rotate, and then stay there. But that's more for rotation of the vertebrae. But I think the same thing could be applied for some of these techniques as a home exercise. Maybe. I feel like mine could have been. Like, you can grab this and rotate yourself.
Yeah.
Sam, I really like that cueing of the double chin too, because I followed the, I don't know if you guys follow Move You on Instagram.
I do. I love it.
And like the guy, I remember, because that's one thing I'm working on right now is like fixing my posture and stuff, because it's been crap from college and stuff. And he always does one on fixing like cervical muscles, and his cue was making a double chin and then going back or whatever.
Yep.
So that's a good cue, especially with your patient population. I think that's a very easy kind of trick to teach them.
Mm-hmm. That's why I have a beard, so I can hide my double chin.
Guys, I sit here with like the most horrible posture. Like,
I know, I'm like, ugh. All right, cool.
I'll go next. Last but certainly not least.
You're lucky I washed my hair today.
Okay, so I'm gonna be doing. I am doing the open muscle energy technique. So Cam did the closed. I'm gonna do the open. So same thing. You're gonna have them. You're gonna want to get them into retraction. That's what I told myself too. You're gonna want to get them into retraction. You're gonna want to find the transverse process for this one. and you're going to want to do a pincer grip on that. And then for the open, you are going to side bend away from the pane. And then you're going to have them turn their head towards their pane. And then you're going to do the same. So you're going to have them resist and then relax. And I'm going to push them to a new barrier. And resist, relax, and new barrier. And then I can bring them back here. Again, we want to make sure that we're on that transverse process of C1. Kind of hard to find the whole time, so you want that pincer grip there. I'm not really tall enough to get my hip up to cam, so I do have to do it in my hands, which is fine. It is just kind of difficult to twist and do both. So the main one about the open is that you're going to side bend away from the pane, and then you're going to rotate towards it. So the close, I have to think about it so hard every time. Side bending towards your pane, and then twisting, rotating away.
Yep.
Open is away and then towards. I don't know.
So-
An easy way to remember that if you guys have one.
I don't.
You have to like
Think about it.
think about it.
And dumb question, I missed the boat. What are the indications for open versus closed, or closed versus open?
If you can side bend and rotate towards your pane, then you do a closed.
Okay, so it's just really all about how much motion they can achieve.
Yes.
Yes. So
Okay.
like if I have pain, if my pain's on my right side and I have pain twisting towards it, that would obviously be a contraindication of doing the closed one.
Okay.
But if I have pain on my right side and I have pain when I rotate away from it, then that would be a contraindication for the
Oh, that's right. That's right. It's coming back to me.
yes. So that's the biggest thing there. So like some people like would have with rotation towards the pain, then you don't want to rotate them towards their pain or side bend them towards their pain.
Gotcha. Thank you.
So I guess one thing, Kendall, that you kind of brought up was that this table wasn't like good for your height.
No
Like,
tables.
I guess what kind of tips and tricks could we figure out for some of these techniques that like, if you have small hands?
Mine's adjustable.
Yeah, but okay, so but like other like besides that, like if a table's like, not adjustable, or if you have small hands, like if somebody's like on mine, if I don't have my giant hands, if I'm Kendall and I have small hands and I'm trying to use the pincer technique to find that transverse process on some guy with a huge neck, it's just jacked. Like kind of like what kind of stuff can we figure out for that? That's kind of my curiosity.
Ironically, this has been something every single time we turn in a technique reflection, I always comment that I'm short and have small hands every single time because it has been an issue for me every single time. So with this one, most people's necks aren't big enough for me to not be able to do this.
Yeah.
Hopefully your transverse processes are not this big. So that one I don't have. I got a crate at work and I flipped that baby upside down, and that's the easiest way that I can get to where I need to be with some things. I sometimes will like level myself out underneath the table. I just stand on whatever's around. That one, I think I would just have to hold the entire time. My hands are very small, so even like his head was really hard to rotate for me because I couldn't get a grip around it. So a lot of the times I have to use both.
They have I think I saw in a catalog like immobilization pillows that almost have that cervical cutout, but then different firm intensities. Could we use a tool like that to lock it so both of our hands are doing the rotation or the holding?
yes, potentially. I know that Dr. Powden said you can, for that, keep their head on the table. You just wouldn't necessarily be able to feel the transverse processes as much.
You wouldn't be able to feel that movement
Right.
or the stiffness.
Yeah,
So you wouldn't be able to feel the
you would just
mobility.
be able to do the technique, which I think that would be okay if you can't. Like,
Well,
even if
and
I
if you-
stood
and if
on
you-
my AirX pad at work, I think I'd be tall enough. It's been an issue, I promise you, with every single technique. If I stand on my AirX pad, I think I'd be tall enough to kind of put his head in my hip. But small hands, short legs has been an issue consistently.
Guys, this is our $1 million idea that we can put in Medco and we can retire right now.
Let's do it.
We got to figure out our little trick or tool.
Something that expands.
Let's just make bionic hands that will grow and contract.
Let's just make a hand that extends from your wrist. It's just like a mannequin hand that just extends from
extra hand.
provides support.
That's all you need is the extra hand.
So I'm glad you brought it up, that I got to talk about it out loud instead of putting in my reflection. Again, I am too short for this.
Kendall, you're not alone. I do that every time too.
Kendall, I'm the opposite. I always say that, like, when we were doing like the lumbar gapping, I was like, I could see how this could be a struggle for a little person. But like, since I'm tall and lanky, I can just like spread out my arms and they'll be like the length of somebody's torso.
Even sometimes like stretching a hamstring. I'm like, I'll get So, welcome to my life.
Love it. Awesome, guys. Great conversation. I really, truly appreciate it. Well, I always enjoy these conversations, but that's besides the point. Do you have any final comments, questions, anything like that we want to try to cover?
The only question I had is how soon after onset would you do it? So if a patient wakes up with a stiff neck, are you going to try it on day 1 or are you going to wait until day 3 or 4?
I would almost say just try it from day 1. I mean, what are you going to hurt? Why allow the patient to live with pain or increase stiffness?
Is there a chance that it would increase stiffness if we can't get them to truly relax though? Or increase guarding, I should say. I don't know if I have the answer. I'm just.
No, and that's a really good question. But I think a lot of that would actually come through your cervical spine evaluation, wouldn't it? I mean, if you're doing a thorough eval.
Right. I think it would be depending on, Thomas went to mechanism of injury, like why is this happening? And you'll figure that out during your evaluation. And is it contraindicative of these, then you wouldn't do it. But if it is, then it's something that you could do right away. Right? Because mobilizations, there's so many different kinds, right? Even Dr. Cowden mentioned there's 1, 2, 3, and 4 really that you could do with your the mobilizations that you guys said. So 1 and 2 are for range of motion and pain. You could do those right away, right? 3 and 4 maybe you would do later.
That's a good point.
Because I know one thing, like when I'm doing like a cervical spine eval, and like a lot of times I'll get kids that like sleep wrong, like how Annette, you were talking about that. I'll see if it's like an actual like muscle thing or if I can get them to relax and passively get them through that full range. And it's just kind of an active issue. And it's something that we can like heat and stretch or something along those lines. Or if I need to do some other technique besides kind of just having them heat and stretch it out, or if I need to do something like this, where I'm kind of more hands-on manual therapy than just like heat and stretch.
So sorry, Annette.
Go ahead.
I'm going to be completely honest with you guys. This cervical evaluations are my weakness. I think cervical spine and spine in general are my weakness because I find them very scary because there are some things that can happen in the neck and in the spine that are very serious. It's not like, oh, you have an ankle sprain. So I am hesitant So I'm glad that we're kind of finding these, because Dr. Cowden did say that not only can these be used as a therapy technique, but they can also be used as a test. So this kind of adds to that book that I have now, because I am scared to do neck evaluations. I refer them pretty quickly. Let's be honest.
Okay.
Like if I'm not pretty sure that it's nerve impingement or a whiplash kind of thing, I'm pretty quick to refer.
One thing that may help you too is getting confidence with the thoracic spine for cervical issues. So let's take, for instance, tech neck, which is a very common thing in today's US. So if we have that forward head, that rounded anterior shoulders, what we're going to lose the curve in our C-spine. We know the thoracic spine is going to have to increase its kyphosis. So maybe it's a thing where we just say, I'm not going to touch your neck. Let's work on getting the thoracic spine upright, loosening some of that increased kyphosis to see if we can get some lordosis back in the neck. That's one thing, at least for me, I was comfortable working thoracic spine because it was going to take a lot for me to cause any harm. Versus the neck, like you said, it can be daunting.
Yeah.
Regional interdependence. That was the biggest thing that I learned when we were at GLADA, because Connor Burton gave a talk about, it was something about the shoulder subluxing, and they ended up talking about, it ended up going down to like lumbar spine and SI joint, but they looked at regional interdependence, which is like when you have mobility, then you have stability, mobility, stability. So then when you get that, so like when Annette was talking about that C-spine and you're getting that stability there, you could have some weakness in that T-spine that could causing you to kind of flip-flop the mobility and stability aspect.
So,
I'm still kind of reading into it because it's like one of those things that I'm finding like super interesting, because it's literally like everything is 100% connected.
So how about if somebody comes into your athletic training facility and says, hey, my neck really hurts, where do you guys start? I feel like I start somewhere different every time because I'm not systematic enough about my evaluations of the neck yet.
I always go head down. Like, I go crown down. Like, and then, like, I make sure bony prominences and everything are good. And then I go to muscular.
Okay.
Does that make sense?
Yeah, so you start bony palpations first.
Well, I start, like, so I'll do, like, dermatomes, myotomes. So I do, like, neuro.
Okay.
Start, like, and then palpations I'll start, like, crown down.
Okay.
And then I move out to muscular.
Okay.
That's how I've always done it. Just because I try to work from, like, internal to superficial.
Okay.
That makes sense?
Yeah.
I guess that's how I always thought
Yeah.
of it when I did it.
Yeah, I mean, I always usually are like, oh, do you have any numbness and tingling in your arms? Just so that, like, if they are, then we can kind of be more concerned about.
Well, and that's kind of funny that you mentioned that, because I've actually had patients and I'm like, do you have numbness and tingling? And they're like, oh, I feel fine. And then you actually, like, do dermatomes and myotomes, and you run, like, over, like, a patch of skin, and they're like, wait, I can't feel that.
Yeah.
And it's like, so you have numbness, and they're like, yeah, but I never realized that because it's normal for me. So that's something we need to always be careful of too, is I got out of the habit of just asking, do you have numbness and tingling, and actually performing, like actually touching skin.
That's a great point, Cam. Thank you.
I know one thing that I always look at, and I think it was just because it was drilled into us in undergrad, was whenever somebody comes in with neck pain, I always look for meningitis, because we had a kid, an AT student, pass away from it like way prior to us. And so that was one thing that they like drilled into us hard, our preceptors. Because I remember one day we had a kid come in and he just had neck pain, and it was just like stiffness. It wasn't like meningitis. But I remember he left and my preceptor looked at me, he goes, what are the signs of meningitis again? And I remember like I was like he didn't have a cold or anything, or like cough or anything along those lines. So I was like, he was fine. And he's like, okay. But it was one of those things that like I was just like, wow, like you always have to check.
I had a patient have stiff neck, but he had a fever, and so he ended up having meningitis.
I caught it about a couple of months ago too.
Yeah. I've had that happen to me in the fall.
Yep. That's when
Yeah.
mine happened.
Yeah.
Kid was in emergency surgery that night.
Mine was just viral, so he got over it. But yeah.
Yeah, no, mine was bad.
Yeah, so that's my thing. I think like with neck, like you have those red flags that like if they have this, like I automatically just clear that to make sure that that's fine, and then I'll move on with that.
Mine's always, I always am like, is it sharp and shooting or is it dull and achy? I think that makes a big difference. If it's sharp and shooting, then that's like bing, 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 bing. This is not going well. Dull and achy is more like, does it feel like a sore muscle? Like you've worked out really hard, blah, blah, blah. That I can then maybe lead my questions more into, did you sleep wrong? Like, have you been working on the computer more? That kind of stuff.
Mm-hmm.
Kendall, the only thing I have to add to my eval is I try to do everything in the position that they came in. So, you know, if I'm in a clinic and they sat down in the waiting, or not the waiting, but like the initial chair, then I'm going to try to do as much as I can in that chair before I make them get up, walk to the treatment table, sit down, lay down, flip over, just because people with neck, they're going to be guarded with every movement.
Right.
So,
Yeah.
that's
And
my
we
input.
talked about that, our SI group too. Like you don't want them to be up, prone and supine, prone and supine, prone and supine, because it's hard to get there. So I think that if you, again, are very systematic, but sometimes I'm not. I'm like, oh, let me do this test. And I'm like, oh, I want to do Spurlings. Can you sit up? And then, oh, I want to do this. Can you lay down? So I need to be more confident in.
Well, I think just like you had said in a previous group work that your rehab plans, you will write out what your rehab plans are before you have the patient come in for the day. You could probably even try that with your evals. Throw some things out there. Be like, I'm going to write this out and see if this makes sense. Not that you have to look at your sheet every time a neck patient comes in, but that's may give you some confidence too.
Right, maybe just write it out so that I get more used to what we do first. This is just like the shoulder thing that we learned at PhD. Like he does it the same every single time he does his shoulder evaluation.
Yep.
Kendall, we can talk about this because I'm working on going through that right now too. And I talked with the BU people about how they go about it. So to talk about it sometime.
Let's all get together and talk about it.
Cool, thanks.
I agree.
Cool. All right, guys. Well, awesome talk. Sorry, we're cutting time a little short here. We got less than a minute left in our video, or in our time. So thank you very much for all of your input. I felt like it was extremely helpful. Hopefully those that watch this will get some good information out of it. And we've got some good questions for Dr. Powden, I think. So if there's nothing else, then I think we could